So I'm a hematologist. For those of you who are more interested in arterial clot apologies, we now have to talk about venous ones. But I promise I will try and finish on time for the break. And just quickly to start, a little bit about nomenclature. The terminology that I'll be using will be direct oral anticoagulants, so abbreviated as DOACs, and this is the preferred term from the ISTH-SSC, the Subcommittee on Control of Anticoagulation. And this is preferred to the abbreviation DOACs because NOACs have been used variably to mean new or novel, neither of which is actually very true anymore. And worse, it's potentially misinterpreted as no anticoagulation. So DOACs is what we should probably stick to. And the development of the DOACs have really revolutionized the way we think about managing therapeutic anticoagulation. But this has not always been the case. So if we look back through the last 100 years in anticoagulant history, the heparin was discovered in 1916 by a second-year medical student, J. McLean. And those of us, including myself, who were junior doctors in the early 1990s, will remember much time spent making up heparin infusions for treating acute DVT and PE, and then more time spent taking blood for APTT monitoring to titrate the heparin infusions and monitor. So this is obviously because heparin has to be given parenterally. It's very poorly absorbed orally. And because it's a large sulfated polysaccharide molecule with lots of positive charge, it has a propensity to bind to anything that's negatively charged, like plasma proteins, cells, and endothelial surfaces. And this binding is very variable, so the dose to anticoagulant response is unpredictable, therefore requiring the blood monitoring. So we were all very relieved when low molecular weight heparin came into clinical practice in mid-90s to the late 1990s. These low molecular weight fragments had much better pharmacodynamic and pharmacokinetic properties, much less propensity for binding, almost 100% bioavailability with very predictable dose anticoagulant response. Then on the oral side, dicumarol was first purified from moldy hay in 1939 by a chemist, and warfarin, which is a synthetic derivative of dicumarol, entered clinical use in about the 1950s. And then for the next 60 to 70 years, really there was no other oral anticoagulant known to mankind apart from warfarin until these direct oral inhibitors were developed. So really, they have changed the way we think about managing VTE, and in the ACCP guideline last year, they were recommended over the use of low molecular weight and warfarin as first choice for treatment of VTE. And the Anticoagulation Forum guidelines also recommend using the DOACs as first choice for outpatient treatment of VTE. Before we come back to low molecular weight heparin, which is what I've been asked to talk about, I just wanted to quickly ask the question of whether or not warfarin is obsolete. And the answer is obviously definitely not, because warfarin costs next to nothing. So even though the price of the DOAC has come down considerably now, this price differential is obviously still going to be very important in low-income patients and in low-income countries. And of course, the major registration studies for VTE excluded a number of important subgroups. So these included patients with prosthetic heart valves, and at least one head-to-head comparison with dabigatran shows that dabigatran is inferior to warfarin in this population of patients. Again, severe renal impairment. The DOACs are reliant on normal renal function for clearance. So patients with creatinine clearance 20 to 30 were excluded from the studies. Patients with heparin-induced thrombocytopenia, although now there is increasing experience of their use in patients with DOACs, where there is a labeled alternative, DOACs should be avoided. And although antiphospholipid antibody syndrome was not actually excluded in the major registration studies, patients were not routinely tested for the antibodies, so their experience is also still limited. So complex thrombosis were generally not represented in these large randomized studies. And if nothing else, it's still very cheap and effective rat poison. Now, the case for low molecular weight heparin is a little bit more difficult to make, because now actually the low molecular weight heparin is more expensive than the DOACs day to day, at least in this hospital. And also, who wants an injection when you can take a tablet? But hopefully, in the next 10 minutes or so, I will show you evidence to suggest that it is still the standard of care in the setting of cancer-associated and pregnancy-associated thrombosis. So if we start off with cancer-associated thrombosis, the landmark study that established the role of low molecular weight heparin as the standard of care for treatment of clot-associated thrombosis is the CLOT study. This was published in 2009 from Canada. They included patients with an objectively confirmed episode of DVT and or PE who were within 6 months of either an active cancer diagnosis or treatment for cancer. And these patients were randomized to either treatment with dalteparin for 6 months alone or treatment with warfarin after initial overlap with dalteparin. In the dalteparin-only arm, the dose of the dalteparin was reduced from 100% to 75% after the first month. So the last 5 months of treatment was actually on 75% dose reduction to obviously try and reduce the bleeding risk. The primary efficacy outcome was symptomatic recurrent VTE, and the safety outcomes were major bleeding and all-cause mortality. So the results for the primary efficacy outcome, there was a statistically significant benefit in terms of reducing recurrent VTE events in the dalteparin arm. So this was 8% compared with 15.8% if they were given warfarin. So a hazard ratio of 0.48 relative risk reduction of around about 52%. And there was no difference in major bleeding or all-cause mortality between the two groups. So it looks quite convincing. But even 10 years after the study was published, warfarin remained in widespread use, probably because of cost and also partly because it's still an injection, so not convenient to take. And there was lack of a confirmatory study. And in 2013, the authors decided that it was time to address some of these gaps. So the CATCH study was designed and started, and this was published in 2015. And they recruited similar population of patients, so those with active cancer or treatment within 6 months of diagnosis of an acute DVT or VTE event. This time, many more patients, and they also included centers outside North America. So the Middle East, Asian countries were also, patients were also included. And here, they randomized patients to treatment with tinzaparin alone for 6 months or warfarin after initial overlap with tinzaparin. So they picked tinzaparin because it's the highest molecular weight of all the low molecular weight heparins and the least dependent on renal clearance. So maybe a better safety profile. And the other thing they also didn't do here was that they didn't reduce the dose after the first month. So 100% dose for 6 months, and with the hope that maybe they might see better efficacy. The primary efficacy outcome was actually a composite outcome. So it was recurrent VTE, but they also included incidental VTE. And the reason for that is because at that time, there was already accumulating evidence that these patients had a similar prognosis to those with symptomatic VTE in the cancer setting. The safety outcomes were the same, so it was major bleeding and all-cause mortality. So the results, unfortunately, the primary efficacy outcome did not show statistical significance. So it was clinically, it showed a clinical trend towards reducing the incidence of recurrent VTE, but the p-value was 0.07. So the incidence in the tinzaparin arm was 7.2% and warfarin was 10.5%. So the reason for the lack of statistical significance was thought to be because the event rate in the warfarin arm of 10% was actually lower than what was anticipated. So they actually powered the study with an anticipated event rate of about 12% in the warfarin arm. So it was probably not powered to detect a difference between the two arms. And major bleeding and death was similar. So where else to get evidence? And meta-analysis is one way. This is a meta-analysis that was published in 2014, and they included 9 randomized controlled studies and pulled the results for them to see if they can estimate an effect from the pooled effect of the relevant studies. So here, 5 studies compared low molecular weight low molecular weight heparin against warfarin. And we'll talk about these ones first. And this is the forest plots for efficacy on your left and safety on your right. So in the leftmost column, sorry, I'm not sure where the arrow is here. Anyway, in the leftmost column is the authors for the studies, for the single studies, followed by the intervention with low molecular weight heparin, and then warfarin, and on the rightmost column, the weight or the influence that each study had on the pooled effect, contributed to the pooled effect. So you can see here from the results that the CATCH study, which is the second study by Lee et al., contributed the most weight to the overall estimated pooled effect, but the recurrent VTE risk was actually lower and significantly lower for the arm given low molecular weight heparin compared with warfarin. So the relative risk reduction was around about 48% and close to the 50% that was shown in the CLOT study. So although there was, for the safety analysis for major bleeding, there was a slight trend towards more bleeding with low molecular weight heparin. This is not statistically significant. So this confirms the results that the CLOT study showed when you pull together data from the smaller randomized studies. Then there were 4 randomized studies for DOACs compared with warfarin in cancer-associated thrombosis with just over 1,100 patients, and this is the forest plot for the efficacy outcome. So if you look at the recurrent VTE risk, here again, although there was a trend, it was not significant statistically for a reduction in VTE events for DOACs over warfarin, and similarly for major bleeding, although again there was a trend towards reduced major bleeding events, this was not statistically significant. So the conclusion really here is that although the DOACs look promising, these DOAC studies are not actually powered to show superiority or non-inferiority over warfarin, and we already know that warfarin is inferior to the low molecular weight heparin. So what you really need is a comparison between, a head-to-head comparison between the DOACs to low molecular weight heparin. The other thing the meta-analysis did was also the figures that are at the bottom, the median annualized recurrence risk. So they calculated the median annualized recurrence risk for the patients on the warfarin arm in both the DOAC studies and the low molecular weight studies, heparin studies. So if you compare the two, you can see that the patients on the warfarin arm in the DOAC studies actually had a lower median annualized recurrence risk when compared with those on the warfarin arm in the low molecular weight heparin studies, suggesting that there are actually different patient groups that were recruited. So the patients in the low molecular weight heparin studies were actually at higher risk of VTE recurrence. So what did the guidelines say? They all point out that there is no direct comparison reported for RCTs for the DOACs versus low molecular weight heparin, and everybody is also agreed that the cancer populations in these DOAC studies are likely different from the low molecular weight heparin ones. So they are all in agreement that low molecular weight heparin is preferred treatment, so initially and for the next 3 to 6 months after the diagnosis of acute VTE. And of course, there's other additional concerns for using DOACs in cancer, lack of experience with drug-to-drug interactions, and also concern about GI absorption if patients are vomiting or have bad diarrhea. So fortunately, there are ongoing studies looking exactly at this question of whether or not DOACs are better than low molecular weight heparin, and the largest of this is edoxaban, and that's planning to recruit about 1,000 patients. So until these results are available, I think low molecular weight still remains standard of care for treatment of cancer-associated thrombosis. Now, pregnancy-associated thrombosis is a little bit more difficult, because whatever you give the mother obviously potentially has complications, not just for the mother, but also for the baby. And the recommendations that we currently have to inform on management are all extrapolated from data in non-pregnant patients, and it is unlikely that we will ever see high-quality studies in this group in the form of randomized controlled studies. But we know that warfarin is definitely not safe for the fetus. So if you expose the baby to warfarin in the first trimester, between 6 to 9 weeks, you will see what's called a warfarin-associated embryopathy. And in later trimesters, second and third, there is a warfarin-associated fetopathy with CNS and ocular abnormalities, likely due to microbleeds, and there's also associated late fetal loss and stillbirth. So the fetopathy has been shown quite nicely to be dose-related, and while some people think that a dose of less than 5 milligrams of warfarin in the first trimester is considered safe and not associated with embryopathy, this is probably not the case, as there are reported incidences. So if warfarin is not safe, why use it? And you would consider it if it was thought to be safe for the mother. And the only situation where this has been shown to be so is in patients with mechanical prosthetic heart valves. So this is a systematic review and meta-analysis of the published literature to date. From the inception of the studies databases to 2016. And what they did was they compared 3 treatment strategies. So just warfarin alone all throughout pregnancy, sequential treatment starting with heparin, and then second and third trimester using warfarin, or low molecular weight alone. And from the estimates, what it clearly shows is that if you use warfarin alone, you reduce maternal mortality and you reduce morbidity in the form of thromboembolic complications. But the live birth rate is the lowest in the warfarin alone group. And the opposite is true for low molecular weight heparin. So then the risk-benefit becomes a matter of perspective, whether or not you're the mother and you want to protect the baby, or you're the doctor and you want to protect the mother. And luckily for us, we don't have that problem when we are looking after pregnant women who have VTE, because we have a perfectly safe option for both the mother and the baby, and this is in the form of low molecular weight heparin. So again, when I was training as a junior doctor, we used to use unfractionated heparin, but with the development of low molecular weight heparin, this is now obviously the treatment of choice, not just because of the better pharmacokinetic profile, but because it has less propensity to bind to platelets. There is a much lower incidence of heparin-induced thrombocytopenia, and it also has less binding to osteoblasts, which then activates osteoclasts, causing problems with heparin-associated thrombocytopenia. So we know warfarin is safe for the fetus. It doesn't cross the placenta. It is detected in very low levels in the breast milk, but it has very low oral bioavailability, so it's not likely to be harmful to the nursing infant. Then for the mother, it is also safe. So again, no randomized controlled studies or high quality evidence, but systematic reviews, such as this one published in 2005, looking at studies where mothers have been exposed to warfarin for both treatment and prophylaxis, show that it is safe in treatment doses, at least in these 174 patients that were reported, with low rates of bleeding, no cases of HIT documented, and a low rate of recurrent VTE. Oops, sorry. What about the DOACs then? And all the product inserts say don't use. In the literature that has looked at animal reproductive toxicity, interestingly, apixaban does not appear to have any direct or indirect harmful effects, and FDA gives it a category B classification. But it is detected in animal breast milk where it's looked for, and at least one study has shown that rivaroxaban is present in human breast milk. There is some experience with patients who were inadvertently exposed to DOAC in early pregnancy, and this study looked at or asked for anonymized pharmacovigilance data from all the different companies, and they also checked FDA and EMEA websites, and they documented a total of 233 exposures. So 2 things they reported in their study. The first one was that outcome was only available for 137, which means that the documentation was very incomplete in the pharmacovigilance data. The second thing that they showed is that out of the 137, there was only 7 babies that actually had abnormalities, and out of these 7, only 3 of them were considered to be embryopathy related to DOAC exposure. So the incidence is roughly, at least given the limitations of these studies, was roughly about 2%. And this doesn't compare too badly with the 3% reported congenital malformation in the overall population. So the second finding that this study reports is that the results don't suggest that DOAC exposure carries a high risk of embryopathy and certainly should not use to direct counseling towards pregnancy termination. To try and close the gap in this incomplete documentation of, in pharmacovigilance, the ISTH has set up a registry looking to collect data on DOAC pregnancy exposure. And obviously, if you have cases, you should submit. What do the guidelines say? They all agree that heparin of some form should be used, and most will say that low molecular weight heparin is the treatment of choice. For breastfeeding, actually, all three can be used: warfarin, low molecular weight heparin, or unfractionated heparin. So I think for now at least, and I can't see this changing in the near future, low molecular weight heparin will remain the standard of care for treatment of pregnancy-associated thrombosis. And that's my conclusion slide. And I think I'm on time. Thank you.
Usually the oncology colleagues of ours will always say, oh, it's okay. DOACs are fine. I mean, they read the evidence and they read out the evidence slightly differently. And they'll say, why don't, after you give the patients for about 6 months and they still have active cancer, they'll usually say, let's switch it to DOACs. The risk is lower. You know, the randomized control trials are randomized control trials. We don't really believe them sometimes, they do. So what would you advise them? After 6 months of anticoagulant, low molecular weight heparin, the patient comes to you, the whole abdomen is nothing but a big bruise. Will you tell them, let's switch it to DOACs?
Actually, I have sympathy with that situation. And that is an evidence-free zone at the moment. So no one is very clear after 3 to 6 months what you actually do. And at the end of the day, you know, even recommending low molecular weight heparin as first-line treatment, you have to still take into account the issue of cost and what is acceptable to the patient. So some patients will just not do it. So yes, I have some sympathy with that approach.
So would you recommend low molecular weight heparin still to make the bruise bigger, or to switch it to an oral?
I think all three strategies are probably reasonable, given that there is no evidence.
Okay, any more questions?
Yes, sure. Yes.
Anticoagulation. And therefore the choice of anticoagulation will depend on what circumstances the patient is in. And when he's having acute cancer with chemotherapy, radiotherapy, and all sorts of therapy, then anticoagulation like low molecular weight heparin will be easier to handle, have a more constant profile, and therefore will prevent the recurrence. But once all this chemotherapy, radiotherapy is done with, but if the cancer is still there and the patient is deemed at risk of recurrence, right, and now we know that cancer patients can live for very long, like prostate cancer, breast cancer. Right. And if we deem that the risk of recurrence is still high and require anticoagulation, and we do not have all the factors that make titration of warfarin very difficult, I don't see why we cannot switch back to warfarin, who can offer a good, good level of anticoagulation at a certain cost. So my take is that it is certainly not a sin to use warfarin in cancer patients. Yes. Because a lot of people come up and give me that look and say, what, you want to use warfarin? This man has got cancer. And so I think that low molecular weight heparin is very useful in a situation when it's difficult to titrate the warfarin, after which I do not think it's wrong to use warfarin.
Yeah, no, I absolutely agree.
Okay, all right.